This video is a tutorial on alignment and measurements taken from plain radiographs for the evaluation of the young adult hip and for hip preservation surgery. Here are the author's disclosures. None are relevant to the content of this presentation. In young adults with hip pain, it is critical to understand the osseous morphology in order to assess the current cause of pain, prognosticate, and render treatment. This is frequently determined through quantitative and qualitative measurements on plain radiographs. Significant discrepancies in intermodality agreement between angles obtained from plain radiographs and from CT have been identified. A multimodal approach can be considered that incorporates multiple imaging strategies. In those patients who subsequently undergo surgical treatment, intraoperative assessment is also recommended. Femoroacetabular impingement occurs in the presence of osseous anatomical variants that result in abnormal contact and is associated with the pathogenesis of intra-articular damage and the development of osteoarthritis. Two types of femoroacetabular impingement have been described. In cam impingement, excess bone at the femoral head-neck junction, which is depicted in yellow in the graphic, abuts with the labrum and acetabular articular cartilage with hip flexion. In pincer impingement, the abnormal contact arises from excess acetabular coverage of the femoral head and may be localized or global in nature. Here we demonstrate the primary views taken on plain radiographs in hip preservation surgery. We routinely capture the three underlined views: standing anteroposterior, 45-degree done, and false profile. The standing AP view is preferred over supine as a more physiologic assessment of acetabular morphology. In the anteroposterior view, there are 5 markers that indicate proper alignment of the image. First, we check the symmetry of the obturator foramina, iliac wings, acetabular teardrops, and femoral heads in the transverse plane. The distance between the pubic symphysis and the coccygeal tip should be 1 to 3 centimeters with minimal shift laterally. Both greater and lesser trochanters should be clearly distinguishable. In the false profile view, appropriate rotation is achieved when the distance between the contralateral femoral head and the margin of the femoral head of interest is no greater than 1.5 femoral head diameters. In the image to the right, we are measuring the left hip, and the distance is approximately 1.5 femoral heads from the edge of the right hip. In the image to the left side of the screen, we are visualizing the right hip, and the distance is nearly 2 femoral heads, which is not acceptable for accurate measurements. For proper alignment on the 45-degree done view, there should be clear visualization of the acetabulum, the femoral head, the femoral neck, proximal femoral shaft, and the anterior superior iliac spine. This is a list of common quantitative and qualitative measurements for hip preservation surgery stratified by the radiographic view. We will review each from the perspective of the pathology that the measurement captures. Cam impingement is identified with an alpha angle greater than 55 degrees on either the anteroposterior or 45-degree done view. This is the anteroposterior view. We have marked the femoral head with a circle to locate the center. We first draw a line extending from the femoral head's center that bisects the femoral neck. Next is a line from the center to where the femoral head breaks sphericity relative to our template circle. This occurs when the distance between the red template circle and the bone margin begins to increase at the superolateral aspect of the femoral head in the image, indicating a change from concavity to convexity. We can see the bump that is suspicious for cam impingement, and the measurement of 81 for anteroposterior alpha angle confirms this. The alpha angle on 45-degree done view is measured similarly. We have a template circle, a line bisecting the femoral neck, and a line extending to where the femoral head breaks from our template circle in the superolateral aspect. This gives an angle of 60.9, suggesting cam impingement. Here we demonstrate the indicators of pincer impingement. Focal pincer impingement is identified through a lateral center edge angle greater than 40 degrees, anterior center edge angle greater than 40 degrees, or a tonus angle less than -7 degrees. The LCEA is the most commonly used parameter in the literature. The two images depict indicators of global pincer impingement. In coxa profunda, the acetabular fossa lies medial to the ilioischial line. Acetabular protrusio is more rare and occurs when the femoral head margin lies medial to the ilioischial line. This is the false profile view, and we are measuring the acetabular coverage in the left hip with the anterior center edge angle. We have inverted the image display to make the sorsal margin more visible. The ACEA is the angle formed between a vertical line with the patient standing in physiologic position and a line from the femoral head center to the edge of the sorsal. In this image, the ACEA is greater than 40 degrees, which suggests pincer impingement. Acetabular retroversion has been established as a predisposing factor for pincer impingement. It can be visualized with three qualitative signs on the AP view. In the image, the ischial spine sign is positive when the ischial spine is visible, which is marked with a red asterisk. This is a video depicting positive crossover sign and positive posterior wall sign. In a normal hip, the anterior and posterior acetabular wall do not intersect until the lateral margin of the weight-bearing sorsal. With acetabular retroversion, these two lines cross medial to the sorsal. Here we are tracing the posterior wall margin first, followed by the anterior wall margin to the intersection point. The posterior wall sign is positive if the margin of the posterior wall is medial to the center of the femoral head. Dysplasia, or acetabular undercoverage, is most commonly identified with an AP pelvis LCEA less than 25 degrees, a false profile ACEA less than 25 degrees, a tonus angle greater than 13 degrees, positive posterior wall sign, or a break in Shenton's line. The exact numerical value differentiating normal, borderline dysplastic, and frankly dysplastic hips is somewhat controversial. This is the tonus angle measurement, also known as the acetabular index measurement. It is formed by the angle between the transverse pelvic axis and a line connecting the medial and lateral edges of the acetabular sorsal. Here, the measurement is 19 degrees, suggesting acetabular undercoverage or dysplasia. There are two reported measurements for the lateral center edge angle, or LCEA, as measured on the AP pelvis radiograph. We demonstrate the LCEA Weiberg in this slide, formed by the angle between a perpendicular to the transverse pelvic axis and the line extending to the most lateral edge of acetabular bone. The transverse pelvic axis accounts for differences in height of the femoral heads in the image. Here, the two femoral heads are not perfectly level, and a horizontal line in the image would not correspond to the pelvic axis. The LCEA Weiberg is 17.8 degrees, indicating dysplasia. Alternatively, the LCEA Ogata is a measurement of the angle of coverage of the weight-bearing surface of the acetabulum. The only difference relative to the LCEA Weiberg is that the line extends to the edge of the sorsal rather than to the edge of the acetabular bone. In this patient, the LCEA Ogata is 25 degrees, and the LCEA Weiberg is 30 degrees. The LCEA Ogata angle measurement may be the same or smaller than the LCEA Weiberg in a given patient. These are other radiographic measurements that have been reported for hip preservation surgery but are not routinely used in most practices for diagnosis or surgical planning. We hope that you have found this education video useful. Thank you for your attention.